Welcome, Alvina and Lynda. So we are going to start the session. We're just going to allow Dr. Jacobson. She's just got home from work and she's just going to join us right now. So we're going to start the session by just asking both of you to give us a little bit of just give us a little bit more information about your story and tell us a little bit about yourself. So Alvina, we'll start with you.
Sure. So hi everyone, nice to virtually meet you all through the chat at least. My name is Alvina and I am 36 years old. I'm coming to you from the suburbs around Montreal called Sinai. And earlier this year in March, I was diagnosed with high-grade serous epithelial ovarian cancer. I consider myself lucky because it was accidentally discovered at stage 1, and I'll answer the question right away because I know a lot of people will ask me how was it possible to be detected at stage 1? It's so rare. The reason why is because the mass that was on my left ovary was the size of a grapefruit, so it was like 16 centimeters. I'm 5'2", small pelvis, so it was crushing things in there. It was painful. So it gave me symptoms that usually aren't really detectable in most cases. So I'm grateful, I guess, that there was a huge mass because that's what helped to get detected early. I'm also a mom of 2 young boys who are 4 and 6, who have really been kind of like the motivation and the drive behind all of this and going through treatments, which I just completed 6 weeks ago. So yay, I'm happy about that. And yeah, and I'm here to share more with you and learn from each other. So on to Lynda.
So I'm sorry, I'm getting over a cold. So I'm Lynda, and in 2021, I was diagnosed with ovarian cancer. I have the endometrioid ovarian cancer. I was diagnosed at stage 1 as well, and my gynecologist found it during a routine ultrasound when I had my IUD replaced. So, like you, Alvina, I was very fortunate. I live in Kitchener, Ontario, and I'm a single parent to a teenage boy. So menopause and puberty in combination have been a lot of fun. So this topic here is near and dear to my heart. So we're just a house full of hormones. So it's
Everyone has their own set of stuff to bring to the table, I guess.
Thank you for sharing that, both of you. I'm going to ask you now, Dr. Jacobson is just logging on right now. So I'm going to ask both of you, if you don't mind, to share with us some of the symptoms that each of you experienced when you went into surgical menopause and how those symptoms affected your quality of life. So Lynda, maybe we'll start with you.
Okay, so I was thinking about this when I was prepping for the session, and I think there was kind of 2 sections to it. Some stuff was immediate, like you had all the TV friendly stuff like hot flashes and whatnot. But I didn't realize, there's cold flashes. And one of the immediate things for me that I never really realized and was very impacting was my irritation and aggressiveness that came out. And when I went back to work, because I just had my surgery recovery time off because I didn't have chemotherapy. And when I went back to work, I had a coworker approach me and say, you're very aggressive and this is not like you. So I wanted to reach out and see, is everything okay? But I didn't tell my coworkers what I went through. So that I wasn't prepared for, like returning to work in full on menopause and the crying at work, in meetings, in public, everywhere. So those things were immediate and I definitely wasn't prepared for those. And then there was more long term, like not long term, but things that came up slowly, like vaginal atrophy that I really only found out about at 6 months when I mentioned my pain to my oncologist. Oh, that's vaginal atrophy. You have to moisturize and do this. And, like the dry skin, because I was flush all the time. And, you can't Google anything. Like I learned that too. Don't Google stuff. But, it's because, okay, I need a different moisturizer and a different skincare routine. so there was some stuff like that that's come on slowly, and then there's this fear of like what's going to come next. So that's the other impact. Like, what's the long term? Am I going to get osteoporosis? Am I going to get this? Am I going to, So yeah, so I think it's kind of broken into three different sections, like immediate, you know, symptoms show up and it's, oh yeah, that's your menopause. And then that fear of what else do I have to put up with for the next longest while? So yeah, but it changed me and that made me sad because I'm not me anymore. So
And like you mentioned, how long are they going to last? You don't
mhm.
know what you don't know.
Mm.
Alvina, I'll pass it over to you to share. And
Yeah,
I first, before I do that, I want to
go for
welcome
it.
Dr. Jacobson. And I really want to thank you for coming. I know you are straight from work and we started a couple minutes early, so I apologize for that. We're just at the point now, we're just hearing a little bit about some symptoms and how they've affected quality of life. So Alvina, I'll turn it over to you.
Sure. So I think for me it was a bit confusing because of the chemo, right? So a lot of it was, and that's later I'll ask Dr. Jacobson about it too, but it wasn't clear for me if what I was experiencing were like menopause symptoms or side effects of chemo. And so, for example, in the beginning, I feel like it was way more intense. So when I say beginning, I'm talking about 6 months ago, where I would have these insane like hot flashes, and they would be triggered by like the smallest changes. Like it could have been something physical, like for example, getting up really quickly and walking too fast would just, I'd be sweating like bullets. Or it could be something emotional, like for example, whether it was negative or positive. So being really excited about something because I got a call from a friend that I haven't spoken to in 10 years, or because my son fell off his bike and hurt himself. But like any little like emotional imbalance would just send me into this like sweating kind of episode. And that it was really intense in the beginning. I guess it was right at the beginning when like the hormones were just off the charts, or well, I guess literally like not on the charts at all maybe. So yeah, that's what I experienced at first. But now I would say like it's a bit more just more so in specific moments, more so at nighttime, when there's a bigger change. So it's like the body seems to be adjusting, or maybe I've figured out some ways. But it was mostly, I think that's the one that really kind of I focused on. But now, like listening to Lynda, I was like, yeah, it's true. I relate to a lot of what you said too. I do feel like there was, a decrease in sex drive and all that stuff, but at the same time, chemo, right? So like you're like, I don't know which one was it. But yeah, fatigue, same thing, or hair loss. Well, obviously with chemo, it's gone. So it's like things you kind of don't notice as much until the chemo's over, and you're like, oh, that's the remnants of the side effects are not side effects now, they're actual symptoms of menopause. So I'm still discovering.
Right. Fun things to discover every day,
Yeah,
right?
yeah.
I want to just take a minute now to introduce Dr. Michelle Jacobson. Dr. Jacobson is a menopause specialist at the Women's College and Mount Sinai Hospitals in Toronto, where she directs the Familial Ovarian Cancer Clinic. She did her residency at McMaster University and her fellowship in menopause at the University of Toronto. And she also holds a Master's of Health Science in Translational Research. She is the creator and director of the Society of Obstetricians and Gynecologists Canada's Community of Practice in Hereditary Breast and Ovarian Cancer, and also the primary author of the Guidelines on the Gynecological Management of Hereditary Breast and Ovarian Cancer and Breast Cancer and Menopause. So welcome, Dr. Jacobson. Thank you so much for joining us tonight. And I wonder if you can start by just explaining to us a little bit of the difference between going into surgical menopause or going into menopause naturally.
Thanks so much for having me tonight. And thank you, Lynda and Alvina, for sharing your stories. I've heard them before, but it's always really powerful. And I think every time you speak, you say something new. So I really appreciate hearing it. Thank you for asking. And again, thanks for having me here tonight. I think I see some of my own patients here on the chat tonight. So I'm excited to hear from you guys also. One of the bigger differences between going into what we'd call iatrogenic menopause, which means caused by something a doctor did to you. So that could be surgical or it could be chemical menopause, like what you're describing with chemotherapy induced menopause, is that the symptoms are definitely more abrupt than when women go through menopause in a natural and gradual way. So, normally, for women who are sort of allowed to go through menopause at their time, and the average age for Caucasian women is 51. There's a bit of a difference based on ethnicity. There will be a gradual change in the number of follicles that women have left in their ovaries, which is the number of eggs that they have left. And over time, the brain will just have to work that much harder to get the ovary to release an egg. So instead of it taking 28 days, it might start to take longer. You'll notice you're skipping periods. During those times where periods aren't coming, we're getting maybe some of the symptoms of estrogen withdrawal, but then they'll be sort of saved by that miracle follicle that gets released, and you might get some reprieve or relief from your symptoms. And then all of a sudden one day you realize, okay, it's been a year since my last period, and that's the day that you are formally and finally in menopause. On the other hand, women who go through menopause iatrogenically because of chemo or because of surgery or because of medications that put you into menopause are going to have it be completely abrupt. So they go from having a completely normal ovarian reserve to absolutely no ovaries at all. And then the estrogen, the testosterone, and for about half of the month, the progesterone levels will go down to almost undetectable. And so those symptoms can last longer and they can be much more bothersome than the gradual ones.
Thank you. Thank you for that. I'm going through menopause naturally now, so it's interesting to get all of the different ways and views there. Alvina, I think you had a question for Dr. Jacobson.
Yes. So, talking about chemo, and I guess my question though would be also, like going in, when I first discovered, okay, there's cancer, there's going to be a surgery. My oncologist did mention, like, yes, you're going to go through surgical menopause. But at that time, that was about the only thing I knew about surgical menopause, that it was a thing. I didn't know anything more about it. So I guess my question is, when you're going through a cancer diagnosis and it's like this big life-changing thing, is there anything we can do as cancer patients before we go into the chemo and like we were going to go hit this wall of menopause all of a sudden? Are there any things we can do to prep our bodies or do something to just be prepared for it?
It's a great question. And, I wish that you had enough time between finding out about a diagnosis and starting chemo to make those changes that might actually, allow you to go through even surgical menopause or chemical menopause in a really less bothersome to you kind of way. I mean, in a perfect world, everybody would be mentally prepared to go through menopause. They would be emotionally and mentally prepared for the closure on fertility, if that was a concern for some. And for young women who are diagnosed with ovarian cancer, for them, this may be the first time that they started thinking, actually, this is the end of my fertility window, maybe unexpectedly. So there's a huge, I think, emotional and mental piece to prepare for. But then also, in a way, when you're preparing for starting chemo, your brain isn't really focused on what menopause is going to feel like, right? You've got this sympathetic nervous system firing, your fight or flight, you're armed and you're ready to engage on this journey, and you're going to fight cancer. And that's exactly what you should be doing. And I think part of the reason you get through the trauma of the initial insult to your system, which is surgical and chemical offense, is because you are so ramped up and ready to fight. And usually then afterwards, when you finally get to the other side of the acute treatment, is when you start to realize what the symptoms of menopause are and really reflect on them and feel what your day-to-day life is like. And that's kind of after the trauma when you start to feel it. And that's when you really realize, like, oh my God, this was so much more than I expected. But in a way, I wish that you would sort of hold that feeling, because when you start to feel survivorship, that means that you've actually survived the beginning and the hardest part of it. And at that point, then you are fighting the symptoms of menopause, the changes, the emotional reflection on what you've been through, that post-trauma response, but you're also a survivor at that point. And this is the beginning of the rest of your life. So I always say, like, when you start worrying about your libido, actually, that's a good sign because it means you want to have sex again. And when you start worrying about the hot flashes, that's because you're not focused on the nausea and the pain, right?
True.
So
Yeah.
try and frame it positively. And for everybody, there's a way that a doctor can help you feel better, even if it's not hormones for everybody.
Mhm. So could I ask then, so like, you're right, that makes so much sense actually, because I was thinking about that too. It's like you can't process all of this, in those first initial months where you're just like, what? The C word is now associated with me in my life? That happens to other people, So when you're just processing that reality of like, oh no, yeah, you got it. So how about this then? So now after, where you're kind of going through, well, in my case, I'll just frame it in my frame of reference. I just finished treatments 6 weeks ago. I probably have some side effects still lingering from chemo, but there's also menopause. So is there a way to differentiate, like, this is for menopause most likely, and this is chemo, and this will stay and this won't? Is there any kind of line that you can draw for us?
So I mean, there's the very classic validated symptoms of menopause that I think many of you will come to know and expect. And those are going to be as obvious as hot flashes and night sweats, where you're waking up at night drenched in your own sweat and your pillow's wet and your sheets are wet. You might not realize that palpitations are actually a sign of menopause, and that sometimes anxious feelings and irritability can be from menopause, and changes to your hair and your skin, which you may not notice after chemo because you thought they were due to chemo in the first place, or you don't have hair anymore. Those can all be signs of menopause. Joint aches, that can be chemo, that can be menopause. So you don't really know what's going to linger until the chemo is all out of your system and you've recovered in a physical and emotional way where you have a new baseline. But that doesn't mean that you have to suffer in the interim, because the symptoms of menopause can be addressed, they can be treated. I think what has to change is the expectation, because you might not go back to feeling the way you felt before your cancer diagnosis. So there's going to be a new normal. And our goal would be to get that new normal as good and as quality of life fulfilling as possible.
Makes sense.
So I love that explanation too about changing the expectation, right? And you described it so perfectly before too, on go in with a positive attitude, right? So you've just overcome this huge trauma and have dealt with so much in your life. So it's a positive thing that you're here now to be able to deal with these symptoms. So can you talk to us a little bit about some of the ways we can alleviate those symptoms? I know that hormone replacement therapy may be an option for some, it may not. Can you tell us how we can address some of those symptoms?
Yeah, so this is going to be really specific to the type of cancer you had, the stage, the treatment that you had. In simple terms, the most common type of ovarian cancer, which is high-grade serous, for women who are premenopausal at the time of their therapy, in general, women can be offered hormone therapy. There's actually studies out there that say that it's safe to use, that it can actually prolong disease-free survival and improve long-term outcomes in terms of how long you live. So when I see women in my gynae cancer clinic, which is a menopause clinic for women who've had gynecologic cancers, if they come with a history of high-grade serous, we do use hormone therapy as long as they have no other contraindications. Where menopause is much more difficult to treat is the women who can't take hormone therapy. And there are going to be certain types of ovarian cancer that fit into that category. Most commonly, what I see is the women with low-grade ovarian cancer, because low-grade is hormone sensitive in the sense that part of the treatment is in blocking estrogen receptors, just like we do with estrogen receptor positive breast cancer. So the women who can't take hormone therapy, what we have to really focus on is trying to optimize symptoms with other means. And sometimes it's medications, sometimes it's things like acupuncture and mindfulness, and also optimize for everybody the rest of the things that are going to help you to be healthy longer. So cardiac disease, this is a risk factor for developing cardiac disease later in life. I see people adding into the chat, I have this cancer, I have that cancer. As many different types of ovarian cancers as there are as many different types of rules when it comes to hormones. And unfortunately, many oncologists will be very focused on, we don't want your cancer to come back, and therefore, I don't know, it sounds like hormones would be a bad idea. you really do, when you're premenopausal at the time of treatment, benefit from speaking to a menopause specialist who's spent the time looking into the literature on this. You know, it's an area of cancer treatment and survivorship that's becoming more and more notable and paid attention to in the literature, because each one of you with each of your different stories might benefit differently from different types of treatments. So you can't make big blanket statements overall. I saw someone had endometrioid. Well, depending on the stage, sometimes we do use estrogen. If we don't use estrogen, we can actually use progesterone. So there are different options out there, but I don't know how to prescribe chemotherapy. And just like that, I wouldn't expect your oncologist to know how to prescribe hormone therapy. So, you know, if you can access a menopause specialist, then it really, I think, behooves you to do so, because you'll get an individualized assessment.
So on that note, I'm going to turn it over to Lynda, who does have one of those other kinds of cancers, ovarian cancers.
Yeah, so excuse me. So I had endometrioid ovarian cancer, and I've been told no hormones. And when I asked about menopause, the oncologist is just like, well, this is your life now. You have to get used to it. And I'm 2 years out now. So I have like a certain acceptance of my symptoms, right? Like, even though some of them have come the hard way. And so I guess the question is, kind of twofold of, this far out, is there anything that I can do to, kind of help mitigate some of the symptoms I'm having, like finding a menopause specialist? But the other thing is, there is that risk of osteoporosis and cardiovascular disease and those kind of things. And how do you get, you know, even my family doctor to be, can I get a bone density? Well, no, you don't need one. You're too young. Can I have this? No, that's not to worry about. So, how do you how do you move forward when you can't take the hormones and you have all these risk factors to help mitigate that and the symptoms? It's just
Oh, I mean,
a
it sure
lot.
sounds like it's hard for you to try and advocate for yourself with your family doctor, and that's tough because it shouldn't be that difficult to do so. You should be able to look to your family doctor, oh, we have a visitor, as your, source of information and advocacy. One thing that I'd suggest if you're having trouble advocating for yourself is come armed with some literature, and usually guidelines are a good way to do that, even if you don't understand what they mean. You can print out, whatever premature ovarian failure or premature ovarian insufficiency guidelines are out there and say, look, like read this and this tells you what to do. Like you don't have to know this, or ask to be referred to an endocrinologist or to a menopause specialist. But what should you be doing? Well, anyone who has premature menopause, which is menopause before 40 or even early menopause before 45, should have their bones assessed. I usually do a bone density about a year after treatment, because we want to really know what are your bones doing when you're at your baseline, your status quo. If I test your bone density the day of your surgery, everything's going to be normal, right? Because you haven't lost the estrogen yet, and your bones haven't had the time to suffer from that loss of estrogen. But a year after that, we should have a pretty good idea of where you're sitting. And that's going to allow us to make recommendations about how to optimize your bone health and how often you should have screening going forward. Similarly, when it comes to cardiac disease, there's a really long time between premature ovarian insufficiency or premature menopause and when cardiac disease is going to develop. So I like to think of this as a risk factor for cardiac disease. That means it's a risk factor you can't change or a non modifiable risk factor. So just like a family history of cardiac disease, this is one of those things. You can't change how old you were when you got your period for the first time. You can't change your family history of cardiac disease. You can't change the fact that you went through menopause prematurely because of your cancer treatment. So what can you change? You can change the amount of alcohol you drink. You can change whether you're a smoker. You can change how often you exercise and the foods you eat, and your diabetes control and your blood pressure management. These are all things that have a huge impact on cardiac disease and cardiac disease outcomes. Yet people who aren't faced with the fear of cardiac disease don't pay much attention to them at all, right? We have tons of uncontrolled diabetics drinking too much alcohol, smoking cigarettes, and living sedentary lifestyles, walking around the street because they're not worried about cardiac disease because they didn't go through premature menopause. So this is for you guys an opportunity to say, this is something I'm worried about. So how can I optimize all the things that I do have control over? And so that's what I usually suggest to my patients.
It's interesting. Thanks. but I want the magic pill to fix it all.
We're all waiting to hear that, but no, I don't think we're gonna. Lynda, did you have another question?
So I guess along the same guidelines, and you talk about advocating for yourself with the family doctor, there's also the when it comes to other people, how do you explain it to other people who really have no idea? Like, I guess it's a twofold thing. I'll try and figure out how to articulate it right. But, you know, I'm in menopause and people are like, you're too young. No, you're not. And then you're like, well, I had ovarian cancer. Oh, and then they, oh, well, it's just menopause, and, or they've had 10 years to go through it and their body gradually goes through it, but we get it immediately. Like, do you have any tips on how to explain to people what you're going through when, it's hard?
It's really hard. And like, I think my overall impression is that people suck and they all say the wrong thing. Like, you know, my pregnant patients, like everyone tells them they're too big, they're too small. Are they having twins? They look full term. They tell, the menopause patients hear exactly what you're saying. Our previvors, our rack up previvors. Well, look how lucky you are. You get a free boob job, right? Like people all say the wrong things and they suck. So what I usually have started doing is just looking at somebody and saying, why would you say that? Or because I don't think I really don't think that you can explain to them what you're going through. You could try, you could say, I appreciate you saying that, but our experiences are quite different because this was a really abrupt change for me. And there's actually some significant health risks that are associated with it. But I think just sort of explaining to them that your menopause and their menopause are not exactly the same. I'm not sure that you're really gonna yes, you can eat a candy, that you're going to really get anywhere by trying to explain it to them because they don't really understand how you feel and they're never going to know exactly how you feel and they're never going to know what it felt like to go through this. So I would just do my best to sort of, like I tell my kids to say, like, you're hurting my feelings. Can you stop doing that in the nicest possible way? Because they may not realize that what they're saying is lacking in empathy. But it's not just in regards to premature menopause. It's everybody says the wrong thing always.
And I guess I can use my menopause to blame my bitchiness on if I
Yeah,
respond back like that, right?
absolutely. And I don't even think it's bitchy to say, like, why would you say that? Like what I've gone through is traumatic and has been physically and emotionally devastating. You can't compare what I've been through to what you're going through.
Yeah, it's a struggle. So
Yeah.
Dr.
But I do
Jacobson?
think, sorry, just to expand on that a little bit, like I do think it's time for us to start recognizing how menopause can impact your functioning in the workplace, right? There's a big paper that came out recently from the Canadian Menopause Foundation that talks about the way menopause symptoms affect women at work. So this is something that's being talked about. Menopause specialists around the country are constantly saying, menopause is having a moment. But your menopause it should have an even louder moment than maybe even natural menopause. And natural menopause is only getting its airtime for the first time now. So we're really at the beginning of spreading awareness for what you're going through.
And thank goodness for that. Thank goodness they're starting to create awareness and have some awareness out there. Dr. Jacobson, you talked a little bit before about some different types of complementary therapies that may help to alleviate some of the symptoms. And I know very specific to whatever type of ovarian cancer. Are there any that you can recommend that may help to alleviate some symptoms?
Yeah, so like assuming we're not talking about hormone therapy right now, we're talking about what we call non-hormonal management of menopause symptoms. And if you're interested in reading more about it, you can look at the North American Menopause Society, which is now just called the Menopause Society. They've got a guideline that came out for 2023 that goes through the management of menopause symptoms that are non-hormonal. So they have lists of things that are evidence-based and show efficacy, and lists of things that, not to say that they're not good for you, but they don't necessarily help with menopause symptoms. So there are certain medications that are non-hormonal, but that have a side effect of helping with hot flashes, night sweats, and mood. There are other medications that have previously thought to be helpful to treating hot flashes that actually have been taken off of the recommended list. Things that are non-medication based that are recommended are things like paced breathing, cognitive behavioral therapy, acupuncture, things that are not recommended for hot flash management, but are still helpful in general, are going to be things like mindfulness and exercise, maintaining a normal body weight. These are things that are going to help your overall well-being, but may not specifically help with hot flashes. There's lots of herbs and supplements out there. Unfortunately, none of them have ever been shown to be better than placebo at treating hot flashes specifically, but that doesn't mean that they have no benefit to them. So I always say, just because, the results of a study, which look at populations, don't necessarily apply. If you try a supplement like a black cohosh or something and you find it helpful, even if that's just placebo effect, if it works 30 to 40% of the time, that's a win for you.
Yeah, great advice. I'm going to ask Alvina and Lynda now on the back of that conversation can you share with us some of the tips and tricks that you have used to help manage some of your symptoms?
Yeah, so one thing I noticed with time over the last 6 months was that there are little things that I was doing that would give me different results. So for example, the worst symptom for me were the hot flashes at night, because it was like a puddle in my bed. It was just a gross feeling, to the point where there were nights where I would get up and shower and wait for my bed sheets to get dry and just be so angry and just be like, what is this? So I really needed to figure out, like, how can I lessen the intensity of these? So what I noticed was that at night after supper, if I don't go have a snack that's like carb heavy, it really like helped me have a better night. I slept better. And I feel like I didn't sweat as much. I don't know if it's just in my head, or maybe Dr. Jacobson can maybe tell us a little bit, but I really felt like whenever I had like a sweet kind of carby type of snack, it really, and maybe it's because my digestive system would like reignite, and that reignition was like making me sweat. So if I just, had supper and didn't like go get a snack at night, I felt like I had a better night. I didn't sweat as much, and it really helped. Yeah.
So like what you've described there is identifying triggers. And everybody needs to do that for themselves, because everybody's triggers are different. There are common ones like spicy food, caffeine, alcohol, all the good stuff. But that's not going to be true for everyone. So if your thing that you enjoyed doing but brought on, a more sleepless night was carbs at night, then just identifying that is really helpful. And I think we've really gone far from paying attention to our own bodies and documenting these kinds of things.
Yeah.
Like, it's this return to listening to your body, which is hard to do when we're so constantly being, our energy and attention is divested. We've got our phones. We're not really listening to ourselves. So when you do that, you will probably find things that work for you. And it doesn't matter if they work for other people or not. I always tell people, like, there's actually not a rule that says you have to sleep under the same blanket as your partner. Like, if you're in bed at night and he or she is cold and you're hot, sleep under a lighter blanket, point the fan directly at you. Use different sheets that work better for wicking sweat, cool gel pillows, silk pillows I saw were mentioned. Any of these things can help, and they don't have to even affect the other people who live in your house.
But I totally agree. Just wanted to just kind of bounce on what you said. It's so true for me. The biggest thing has been this realization of, wow, I've been living my life in my head a lot. I'm a thinker, I like to think about things, and I wasn't living in my body enough, and so for me, it was this whole like rediscovery of living in my body and like acknowledging the little aches and pains before they become bigger problems, just in general, where it's like, oh, like I'm feeling hot, or oh, I've been slouching all day, maybe I should get up out of my chair and go for a walk, which is something I was not listening to, or even had the ability to pay attention to it, because I was living up here only. So definitely great message there.
Lynda, anything you'd like to add?
So this is what ovarian cancer does to you, that, you're going to be on a national symposium and say, coconut oil and Replens, two best friends. No. But anyway, it's true. But the other side is, and I am 2 years out, remember, is self-compassion and vulnerability. Just to greatly expand on it, like to accept the fact that I'm going to have down days. and I'm going to cry, and I am going to lose control of my emotions, and to be vulnerable to share, with my immediate team what I'm going through. So feel free to come and let me know if I'm being, send me a text message on my cell phone if I'm being overly aggressive in the meeting. You know what I mean? Like, to allow that kind of feedback that I probably wouldn't have ever allowed before. And the down days. So the self-compassion was a big part of it. And also sharing very personal things with other women, and you'll find they'll share back, because it seems like as women we all suffer alone. And I know Dr. Jacobson said menopause is having its moment, but for too long it's been in the closet. But I find if I share something a little vulnerable, then the floodgates from other people open up, and in those discussions with the other women, that's when you get a lot more tips and, antidotal remedies and all that kind of stuff. So um yeah, at 2 years out. And then the other thing, Alvina, it's true. No sugar at night. No eating after 8, and definitely no sugar, even on a Friday night, or you're going to get a hot flash during the night. So I find it for me too. Yep.
And
So
like one other thing to say to that is like you talking about self-compassion, like once you recognize your triggers, it also makes you in control. Like maybe alcohol is your trigger and you avoid it most days because you want to have a restful night's sleep. But you can also make that conscious decision that tonight I'm having that carb before bed because I want it and I feel like it. And I'm gonna have some hot flashes, but I'm anticipating it and I'm expecting it and I'm okay because I'm in control here. I think like live your life based on your terms.
because like
Yeah.
before all this, the bar was probably up here, right? Do you know what I mean? For how you doing? Good. Here's my bar. Well, now my bar is down here. And I have to accept the fact that that's okay for my bar to be down here. And eventually it'll go back up here. But that's been the biggest, like, self-compassion, to accept all these changes in me. So
Yeah, and you just adjust, right? So instead of having my chocolate from my kids' Halloween candy at night, I'm having it at lunchtime. It's just about
exactly.
That's a great solution, Alvina. And I mean, I think too, Lynda, that was some excellent words there. And I think that's what we've done in this session tonight too, is opened the channel of conversation, as you can see in the chat box tonight. We have a ton of questions to get to, but we just had one more question, and I'm going to let Alvina ask this one. And I think you've kind of answered it, but it's really important. So I'm going to let you go ahead, Alvina.
Yeah, sure. So like I was saying earlier in the intro, it's, I had heard the term surgical menopause, but really didn't know what to expect and the intensity of how everything would be. So now, when someone like me, where I'm done with treatment and I'm able to, like you said, now process like, oh, there's menopause and there are the symptoms. So who should we be looking for? Like what experts or professionals would be seeking out? Because, as you've seen from our conversation, sometimes our oncologist isn't necessarily specialized in it, neither is our family doctor. So what's the term that we should be Googling, like in terms of professionals to look for?
So, I mean, ideally, a menopause specialist is going to be the person who's most comfortable managing your symptoms. And there's still really a shortage of good menopause specialists across Canada, although it's getting better. My best advice would be to go onto the Menopause Society, formerly the North American Menopause Society's website, and they will actually give you a list of certified menopause practitioners. So, people who've taken a course and written an exam, which really just tells you that they are focused in best practices in menopause management. And most of us now will do virtual consults. So, like I saw people today from Sault Ste. Marie, even though I'm located in Toronto. I've seen people from the Northwest Territories. I think really one of the good things that came out of COVID is we're so much more comfortable doing these things virtually now that we never used to. And that's really improved access to highly subspecialized care.
And do you need to get a referral, or is it something you can look up yourself?
Yeah, you would need a referral if it was a gynecologist or an endocrinologist that you were seeing. A family doctor wouldn't need a referral necessarily. And there are some family doctors who specialize in menopause management. But you could ask your family doctor, nurse practitioner, whoever your primary care is, to refer you to a menopause specialist, and you could give a name. Like you can make it very easy for them. If they're refusing, like you have a problem, with that person. There's no reason that people should be minimizing your symptoms or telling you that they're not real. That's gaslighting. That's medical gaslighting. Your symptoms are real. There are doctors who will pay attention to you. You just need to make it very simple for them to make that referral.
Okay, and just last question on that is, so other than, you know, finding an actual professional, what about in terms of information? So if you want to read about it, what's a place where we could go read actual reputable science-based factual information?
Again, I think the Menopause Society has good resources. So does the Canadian Menopause Foundation. So that's a new charitable organization or foundation that was started by two menopausal women who had a bad go at getting care for their menopause, and they realized how much of a gap there was in medical care. So they started the Canadian Menopause Foundation. And even though that may not be highly specialized in ovarian cancer menopausal aftercare, it's going to be other women who are also struggling. And there are lots of women who can't take hormones, even though they've not had ovarian cancer. And there are lots of women who've gone through menopause prematurely, even though it wasn't from chemotherapy and surgery. So finding common ground, knowing that you're not alone, and being able to access specialized care.
Perfect, thank you.
So we're going to put those two in the chat there. We had the Canadian Menopause Foundation and the Menopause Society. So we'll put those in the chat, sources of excellent information. I am going to get to the chat box now because, like I said, we have about 9 minutes and we have a lot of questions. So Dr. Jacobson, you talked a little bit about an endocrinologist. So that was one of the questions we had, is what role can an endocrinologist play in my care? And how do I go about being referred to one?
So that's going to depend on the endocrinologist. So just like all subspecialties, some endocrinologists are focused on diabetes care and management, thyroid. Others are going to be focused on menopause. So if you see an endocrinologist, they might be more comfortable than a general internist or a family doctor in prescribing hormone therapy or other non-hormonal options, but they may not be the best either if they're not that comfortable with it. So I'd suggest, depending on where you are, really start with a menopause certified practitioner if you're looking for menopausal symptoms. Some of them will be endocrinologists. I work with a fabulous endocrinologist who specializes in women's health and reproductive endocrinology, but it's not all endocrinologists, and they would need a referral as well.
From a family doctor, presumably. Yeah.
Yeah.
Okay, excellent. Next question here is, can you talk a little bit about traditional HRT versus bioidentical hormone replacement therapy?
Yep. So hormone replacement therapy or menopausal hormone therapy, it refers to giving back usually estrogen. And if women have a uterus, then they need to have some form of uterine protectant agent like progesterone as well. Originally, the hormone therapies that were used were synthetic. They were produced out of pregnant horse urine, the different types of estrogen compounds that come out of it. Now they're produced in a lab, but it's the same type of compound. That's called conjugated estrogen. So people tend to think of that as being synthetic because they think of it as non-human. The truth of the matter is, I mean, it's biologic in the sense that it's found in nature, but you're right, it's not something that is naturally found in a woman's body. Over time, there was a movement away from that type of estrogen and into more bioidentical or body identical or physiologic estrogens. So those are going to be the type of estrogens that are found naturally produced in a woman's body. And they might be produced also in a lab, usually from sources like soy or wild yam, but they're going to be chemically identical to what the ovary used to make. Then there was this sort of movement, the bioidentical hormone therapy movement, which is the same type of thing. It's the same type of chemically identical to what your body makes estrogen, but it was moved into, this is more individualized, this is compounded therapy. So this is it. So it moved away from what you could prescribe, and now it was sort of this movement like the Suzanne Summers, we're going to get this compounded and it's going to be individualized for you. The problem with this compounded therapies is that from a batch to batch quality control point of view, they differ significantly. And many women actually got cancer from taking estrogen through the skin, which is absorbed well, but also taking progesterone through the skin, which is not absorbed well. And those women ended up getting too much estrogen and growing endometrial cancer from it. So in general, if I follow, the recommendations of the International Menopause Society or of the Menopause Society, then I'm going to prescribe bioidentical in that they're chemically identical to what your body makes, but you can get them from any pharmacy. They're Health Canada approved, and they're not part of the now coined bioidentical hormone therapy movement.
Okay. So much information. Thank you. Such a great response there. Now, another question then, kind of on that as well, is there a difference, or is one better than the other if we're taking HRT in a pill format or a gel format or a patch format? Again, maybe too individual for you to answer and maybe too broad.
It's so individualized, and sometimes people start on one and they find it's not working for this reason or that reason, and then we switch them to something else. So in a perfectly healthy, average age menopause woman who comes to you with a drug plan and the world is her oyster, she could take anything and it would all work similarly well, and it would all confer a similar amount of risk. But when you have individual risk factors, so perhaps you've got a strong family history of breast cancer, or perhaps you've got a history of a blood clot in the legs or the lungs that happened during your cancer treatment, then we're going to take your individual medical history into consideration and prescribe you something with a safer profile for your individual risk factors.
Key message is you have to speak with a professional menopause specialist about your own individual situation.
There is no one size fits all approach.
No. So a lot of these questions are individual, so I'm kind of trying to weed through them a little bit. This one may affect a lot of people. How long can we stay on the pill? I'm still on it in my late 40s and not sure if I should go off. I was told that my symptoms won't be that high while I'm on it. It might help alleviate some symptoms.
I'm not sure if you're talking about birth control or
birth control pill, I think. Yeah.
Okay. Yeah. So birth control pills, they are a form of hormone replacement therapy. The difference between birth controls and menopausal hormone therapy is birth control levels are supraphysiologic, or higher than what your body would produce in a normal menstrual cycle, because they're trying to suppress your ovulation. On the other hand, hormone therapy is lower than what you would make in a normal menstrual cycle. And so birth control has an increased risk of blood clots in the legs or the lungs as you get older. So usually around 50, assuming you have no other contraindications, is when I would suggest transitioning. And at that point, you could switch to hormone therapy if needed, or you could just try to go off of it and see what your symptoms are like. There is no evidence that taking hormone therapy or birth control prolongs menopause. So it's not like it's a Band-Aid solution where your symptoms are just going to start up again the way they were after 10 years. Most women's symptoms will improve over that time, other than, I'll put this as a caveat, vaginal dryness. So vaginal dryness and the other symptoms that go along with the genitourinary syndrome of menopause, they by definition get worse the further away from menopause you get. There is no timeline after which you should stop treating vaginal symptoms, and we would treat them with local symptoms that don't have the risk of causing anything. So no increased risk of cancer recurrence, no increased risk of blood clots or breast cancer or anything like that. So vaginal treatments for the most part are going to be safe for everybody to use. I've heard people say coconut oil and emu oil, and although all bland oils are very good, but there are also prescription therapies that can be used.
Okay. This question kind of along the same lines, and maybe a benefit of hormone replacement therapy, says that there is some new research saying that hormone replacement taken in the 40s and 50s can potentially help to ward off dementia. Any thoughts on that?
I mean, from my point of view, and you can see I'm very pro-hormone, like we're not there yet. So right now, hormone therapy is really used for the treatment of symptoms, for the management of postmenopausal bone loss in the States. That's one recommendation. And for premature ovarian failure, insufficiency, for the protection against the diseases that we've talked about until the average age of menopause. Right now, the jury's out on whether there's a role for using hormone therapy to prevent things like cardiac disease or cognition changes. So in an average age menopausal woman, I wouldn't recommend using hormones for any reason other than treating quality of life symptoms that are bothersome.
Excellent. So we don't have time for any more questions. Thank you. You kind of got a rapid fire there. We had a ton of questions in there. As you can see, this is a topic that so many people have questions about. And Lynda, back to even just opening the dialogue tonight is so important. I want to thank each and every one of you. Dr. Jacobson, I know how busy you are and we really appreciate your time. So thank you so much for coming and sharing that wealth of information with us. Lynda and Alvina for being vulnerable and real and sharing everything with the group tonight. Again, we truly thank you all for being with us here tonight.